Thank you so much, Eva. Thank you so much for joining this morning with us. We are all aging, and I think this is the topic why we are here. I will really bring it into clinical practice because what we try to do is building an ecosystem to go from animal studies to human studies into clinical practice and have solutions, I would say, for our clients, which is nearly 100% of the population. Here you see Alexandra Hospital on the first slide. This is the hospital in Singapore where we have our clinical studies and where we will also introduce the first longevity medicine clinic into a publicly funded hospital. I know that there are lots of private initiatives, lots of us do that, including me, but I think also that we have to transform the healthcare system as it is. And why do I say that? Because I'm a physician, I led a big amounts of hospital parts, and I think our way, how we treat individuals, patients, is too dichotomous. It's good, it's not good, you have a disease, you don't have a disease, you have an indication, you don't have an indication. So I think that has to change because we know that our organ performance is already going down from our 20s onwards. That's actually when we can measure it. I think we can measure development and the accumulation of changes much, much earlier. Just from a principle point of view, I think we all know that we are changing our phenotype looking at ourselves from our 20s onwards. What is medicine doing? Medicine is just dichotomizing it again. You have COPD, you don't have COPD. Patients ask myself, do you have good news, doctor, or do you have bad news? And that's what we have to change. I think in our healthcare system, we really try to achieve and implement more knowledge to prevent age-related diseases, to prevent the onset of the incidence of an age-related diseases. And we do that especially in older individuals. I'm a geriatrician also by training. We do that in, for example, geriatrics, where we want to prevent the incidence, for example, of dementia and delay it by a couple of years, or the incidence of diabetes in pre-diabetics. And I think the GPs do a wonderful work to do that. What we don't do at the age of 60 to 70 to look at the high performers and say, okay, is this your best performance or could you perform even better? That's not what we have in our genes. I haven't seen any physician in the regular system asking a 60 to 70-year-old, are you at the optimum of your health status? Nobody would ask me that in the 40s, asking, okay, do you perform at your optimal stage that you not only can delay the onset of a disease, hopefully in 20 or 30 years' time for my age group, but also maybe delay deaths and increase quality of life. So this is longevity medicine or healthy longevity medicine. And we just established together with Eva a society. I don't think that at the moment we should start with children in the longevity medicine society or in the arena where we are. But I think at a certain stage, even our new type of medicine will involve men, women who will want to be parents in the end, to give actually the child the best optimum basis of a long, healthy life. Why do we need to maybe create a different type of medicine? This is because we understand why we age. So I'm in the field for 20 years, and I started with culturing fibroblasts, and then they had PDs of population doublings of 100, and then they weren't senescent, etc. We understand why we age. And I think we can say, yes, we understand it in that way, that we can now use the understandings to inform diagnostics. And that's the reason why our field, I think, is really transforming the understanding into diagnostics, in making clocks, for example, which sells well. What is your age? How is your clock ticking? So, and I think the biochemistry clocks are very good. The DNA methylation clocks are very good. I just had to talk at another conference talking about omics. I think we're at the stage where we can inform our individuals, our patients, clients, I don't care how you call them, to build that diagnostic arena that we can not only say how old you are, but maybe also how much we can reverse the age, because we need biomarkers which are sensitive to change, for example, for randomized controlled trials. And I think it's not only the diagnostics, we understand also what's occurring during lifetime, we can intervene. We now have a couple of pillars we can do. It's lifestyle intervention, it's supplements, it's repurposed drugs, it's new drugs. We now can intervene in the aging process. We don't have to wait until we have to ask an endocrinologist, cardiologist, etc., to cure or try to cure the age-related diseases. And I think it already has been discussed in the talk by Aubrey. And Aubrey Martin, thank you so much for inviting all of us. We need classifications, and I think lots of us arguing for ICD-10, 11, 12 coding for the international classifications of diseases. And since 2018, I would say, we have at least a little bit the basis to perform diagnostics and interventions in clinical practice. So this is a website of the Longevity Medicine Society. Please join. On the right-hand side, there is a membership. Very important. What we did, we brought, I would say, a small number of individuals together, we thought, who were like-minded, who wanted to start the discussions, how to inform hospitals, others, about longevity medicine. So you say IFAR here, I'm at the moment the president, near Baselai, Harold Pinkers, Thomas Rando, and James Kirtland. We came together. This is a council of the new Health and Longevity Medicine Society. We met 2 weeks ago. It was founded the 8th of August this year. We came together in Singapore to really define what is longevity medicine, what is our roadmap to actually implement not only the science, but really develop care for aging individuals. What is the aim? First of all, we need a definition. So the definition is healthy longevity medicine is optimizing health span. It's not about lifespan, optimizing health span by targeting aging process across the lifespan. I think this is a very nice overarching definition where hopefully we not have so much debate about that. What are we going to do? We are educating, like we do in such conferences, but I think we really need to educate laymen. We need to educate politicians. We need to educate other healthcare professionals who are not yet in the field. And what our aim is really to build a recognized specialty. First in internal medicine, I'm an internal medicine specialist. I want to become, together with others, a longevity medicine physician in internal medicine. We want to increase quality in the field. I think we need standards. I don't know of much specialties who do not have standards and guidelines. How can we practice without guidelines and standards? So we will form groups. So please just send us an email and join us to bring all the evidence together using the quality reference and frameworks to, for example, say and judge how good are certain diagnostics, how good are certain clocks, how good are certain interventions. Is there enough proof that we would actually recommend to individuals to spend their money to do some interventions, or to spend, or asking the healthcare, the insurers to spend money on it. So we need that guide and the standards. And we want to accelerate. I'm now 20 years in the field. There is a huge amount of investment at the moment. I think there is a huge amount of acceleration of knowledge we have, but I think we have to learn from other specialties. I see from my colleagues in oncology, endocrinology, and in all other specialties, they have huge trial networks around the world. And we also want to achieve that, to just speed up the system and to standardize not only our assessments, but also the interventions. This is very important. I think this is the essence, for me at least, in daily clinical practice and then the research we are doing, what we want to do. We have a great phenotypic characterization using, for example, the omics approach, but also clinical phenotyping, very standardized, and then digital phenotyping, that we actually can measure physiological symptoms continuously over, for example, a cohort study or over of RCTs. So bringing that together, making sense out of it, in phenotypic sense, that we know what individual, of what phenotype that individual has, we will then bring back, knowing what the environment is that that person is living it. Making, for example, changes in the environment, making changes in lifestyle. Think about caloric restriction, intermittent fasting, specific diets where we know which supplements are in there, but then in normal food. And then also adding supplements, repurposed drugs, new drugs, etc. And then the feedback loop that we can measure, hopefully with validated clocks in the end, or validated diagnostics, which are very accurate to see what kind of effect that person or that intervention has at that point in time. We made lots of efforts in the past before I was in Singapore to actually analyze UK Biobank data, because we need a huge amount of data to understand the variation of individuals who are aging at that moment in time or this moment in time. So 150,000 individuals, and what we wanted to do, we wanted to create clocks. Not clocks based on omics data. We are doing that in a couple of months' time, but clocks based on phenotypic data of clinical data we already have available. Every GP could do, which I can do in Singapore with the cohorts and with trials. So what we did, we took all the data from the UK Biobank, roughly 200 variables, and then we built body clocks, a body clock, and organ-specific clocks, to also see how the rate of aging in different organ systems might be different from the aging process of the body itself, and how much interference there might be. So first we applied the first generation clocks, which means that the clock should be associated with chronological age. The second generation clock is we are looking at organ-specific measures, and then we are looking if that clock is associated with negative outcome. We defined the negative outcome as the incidence of a new disease in healthy individuals, and then during the follow-up, if that disease occurred, and of course also mortality. Here you see the body clock, first generation clock. You see that the body clock is associated with chronological age. Luckily, the R is not 1.0, because then we could just ask what the passport age is. I like that the R is between a 0.6 or a 0.8, because then there is an association with chronological age, but there is lots of standard deviation, there's lots of spread variation. And that variation gives you an insight of the biological age, of course. So a 0.7, 0.8 in our study in our hands. We not only looked at the body age, but as I said, also the organ-specific clocks, which you can see in the middle of the slide. And we looked at a huge amount of determinants of that clock. And you don't have to read it, but there is so much interaction of all, for example, environmental factors, lifestyle factors in determining what age a person has. And I will just give you one example. For example, the green space somebody is living in is determining how biologically old or young somebody is. So what I learned actually out of this exercise is that if we do studies, cohort studies, but also RCTs, randomized controlled trials, we have to ask much more. Not only how much green space you have, where you are living, but maybe also, are you happily married or just married? And I think these are very, very important determinants of our biological age and the speed of our aging process. And we can determine already what's happening inside our body. So here you see the summary of a network analysis looking at the decline of organ function, most of the time it's a decline over age, the decline of organ functions of cardiac, pulmonary, muscle, etc., all the organ systems. And you see that there are errors in certain directions, which means if in the first 6 years pulmonary function of an individual is going down in 6 years' time, that's predictive for cardiac function going down, for muscle function, for hepatic function, for renal function. And sometimes it's not the other way around, which means if you have a patient, for example, in the cardiac department with a cardiac problem, you shouldn't refer that person to the pulmonologist because it's unlikely that the pulmonary function is going down, but the other way around, which means that from a health perspective and a care perspective, a management perspective, we can now predict what's going wrong in a body, of course, on group level. We also checked if our new body clocks are associated with the incidence of disease, and yes, it is. So if we have an individual with a higher biological age in the body clock using these 68 parameters, that was very predictive of the new onset of an age-related disease, which you see on the right-hand side of that slide. For example, diabetes, COPD, cirrhosis, and kidney disease. We also did the same for all the other body clocks, so the organ-specific clocks, which you see horizontally. And what you see in all these histograms is everything which is green is significant, statistically significant. If it's yellow, it's even more statistically significant. If it's red, it's super significant. Everything is green, it's not significant. And what you can see is, on the horizontal, if you have a certain organ age, how much predictive that is for the incidence of diseases on the vertical axis on the left-hand side. So what you can see is that even an organ-specific clock of one organ is associated with the incidence of a disease in a different organ, which means that there is an interaction within our body, not a one-on-one interaction, but at least there is prediction. And the best clock was the body clock in predicting the onset of all diseases. And of course, these clocks on the left-hand side, the body clock, but also the organ-specific clocks, are associated with mortality, and the hazard ratios are given on the right-hand side. These are healthy individuals. I just want to give you one example that this also holds in acutely sick older adults, where the mortality rate in 3 years' time is nearly 80%. And this is my resort cohort, Restoring Health of Acutely Unwell Adults. What we did, we had lots of clinical parameters, but also path lab data, for example, creatinine, HB, etc. So we applied a clock to that cohort, the young AI clock, and actually looked at, is that associated with a clinical frailty scale being measured by the CFS during admission? And yes, it is. So it's not only that we should look forward to clocks in healthy individuals in general populations, but we can also apply that, and I think there we need the dialogue, to much more sicker and more aged individuals, as we did. So the age was roughly 85 years, and once again, very frail individuals, and it works. We need a better understanding, I would say, at the mechanisms too, when we apply the clocks. And I will just give you one example. Here you see the entire literature until 2020 looking at human beings where we had information about how much senescent cells. And we just heard in the previous talk that it's sometimes quite hard to define what senescence is. But we looked at senescence, the senescence load in the chronological age in humans. And this is a meta-analysis. And we separated all the data also based on organs. And what you can see that the senescence load is associated with chronological age. It's also with diseases, but it's dependent on which organ you are looking at, which means that the rate of aging in our body might be very different in different organ systems, and the mechanisms behind it might be different. And I think that's the next learning step we have to do. That's the reason why we propose a biomarker core, which hopefully will be set up in Singapore at the National University of Singapore, where we look at all hallmarks of aging, we standardize the measurements, and then we invite cohorts or RCTs to send us the samples that in a standardized way we can measure lots of biomaterial, and then we can learn from it. So what about the identification? I think diagnostics is one. A couple of minutes about possible interventions. We know that physical activity helps to make you younger or to slow down the aging process. I think what we don't know, but Jo-Ming Jo, an associate professor in our group, is really trying to achieve to see, okay, which physical activity, aerobic or strength or whatever you want to do, or balance or yoga, balance training, how is that interfering with molecular pathways in our body, to understand and to better understand what's going on in our body when we do physical activity, and there with individualized training processes, I think, which is the key of nudging individuals to do, for example, dietary intervention or physical activity interventions. And I think we can close the book that physical activity is good for us. These are meta-on-meta analysis we did during the COVID time, lots of meta-analysis, that the steps we take as an individual will give us a reduction of risk of bad outcome. For example, mortality, activities of daily living, frailty, falls, whatever you think. We have enough data to say it's good. Now it's the time to actually ask ourselves, what do I have to do to minimize my risk? So what is the optimal physical activity for me? And when, and what intensity. So that's the next step, in my view, in our fields. The same we have to do for nutrition. We have to optimize individualized nutrition for our clients, for our patients. And we just published a framework to do that in patients, so geriatric patients and hospitalized patients. But the same framework we can apply to longevity medicine. How many strawberries should you eat because of visitin? How much red wine? Please don't do that. Because of a little bit of resveratrol in there, don't do it. But I think this is very important to individualize. We are doing lots of trials. Brian Kennedy is sitting here in the room, really bringing evidence from animal studies into human studies. On the left-hand side of this slide, you see all the parameters or the supplements and repurposed drugs being tested at the moment in Brian's lab in animals. We are bringing that into human beings. The AKG alpha-ketoglutarate study is starting very soon. Rapamycin, Rapalox, Urolithin A, spermidine, visitin, all is in the making to really have a randomized controlled trial center with parallel arms of different ingredients to also be able to have a head-to-head, which is very important, comparison of all the supplements, because we need to know what kind of effect sizes one and the other has. Alpha-ketoglutarate is a very nice, I think Brian will have it in the talk, a very nice molecule with a huge number of actions in mechanisms. But Brian will touch on that. I would like to show you a couple of results we have of an NMN study we did in 80 individuals. First of all, NMN is very important to increase NED levels, which is going down during chronological age. So the idea is to supplement NMN and therewith have a positive effect on human aging. We did a study on, or was involved in the study with 80 men, 50 years of age, no chronic disease. And what we were able to show is, this is non-published yet, that the NED levels with 300 milligram to 900 milligram NMN is going up, and that the 6-minute walking test in the SF36, which is a quality of life, is much better after 60 days of NMN, whereas there was no change in the blood biological age based on past lab data. I think this is the way to go, high quality randomized controlled trials in parallel, looking at the effect size, and then combined with the right diagnostics, hopefully which are sensitive to change. If you're not aware yet, Brian and I, we have our longevity webinars every Thursday. We invite one guest and have a, I would say, great discussion. Sometimes it's real fun. And to educate not only our politicians to get even more an ecosystem in Singapore, but educate worldwide. So hopefully I convinced you that on the right-hand side, on the Healthy Longevity Medicine Society, just press membership and join. That we can maybe not reverse aging, but delay the aging process. Thank you so much.